Okay, so good afternoon. Today's webinar is the Early Hearing Detection and Intervention, also known as EHDI 101 series for New Jersey Hospital EHDI contacts, and this is part 3 of the series on the EHDI quarterly reports, their interpretation, and their use. Parts 1 and 2 we have recorded and are available on our website and go through the regulatory requirements in order to follow the EHDI program's rules and regulations. As with those other webinars that are recorded and are available on the EHDI webpage, the target audience for today's presentation is hospital staff that have administrative oversight of newborn hearing screening in New Jersey hospitals. This presentation will focus on the quarterly data reports sent to each hospital by the EHDI program and how hospital EHDI contacts should reconcile and utilize this information. As you watch this presentation, again, please feel free to jot down any questions that you have. For those listening live to our recording today, you can text your questions in the GoToWebinar question box. For those watching the recorded version of this webinar, jot any questions you have down and you can email or call the Department of Health staff when the presentation is over. Okay. So the goals of the EHDI quarterly reports that are sent out to the hospital are to monitor hospital compliance with hearing screening and follow-up contact requirements, and to also monitor trends in refer rates and follow-up rates to identify areas for quality improvement. We also use the quarterly reports as an opportunity to allow for reconciliation of hospital and EHDI program data and have an opportunity for a quality assurance check of data entry that is entered. Ooh. I lost my screen. And let me just check with my co-coordinator on the phone. Can you see my whole screen? Because I can only see a piece of it right now.
I can only see summary statistics. Go to CEO. I see the letter that you may not want to.
Fascinating. Okay,
there you go. You're back.
Okay. So the distribution of our quarterly reports are that for the summary statistics that we send out twice a year, those must go to your hospital's CEO because we want to be sure that your hospital's administration is included in the goings-on of the hospital's EHDI program. The rest of the distribution list is up to you, but at least one person from each hospital needs to receive all of the detailed level reports, and we'll get into these reports and these pieces of the quarterly report in a moment. So please always verify that your list, which is included on the last page of the cover letter that is sent on when we do send out the summary statistics, includes the appropriate information of who you want the reports to go to. You can have folks get just the statistics. You can get all of the detail reports. We also have some folks that want to get just the follow-up lists. For example, if you have an audiology department that's involved in follow-up but isn't involved in inpatient screening, they may want to get those lists. We will send to folks who are getting the statistics only. We can have those sent out via email if you would prefer them that way. We will not send the detail reports via email because it does include named child level information. But if you do have folks that want stats only, they can opt for the email distribution. So this is the statistics page that I just mentioned, and this is currently generated twice a year. In February, it includes data through the 4th quarter of the prior year. We always wait 1 month after the end of the quarter for follow-up reports to come in on children. So statistics are also run in August, which will include the first 2 quarters of the current year, like you see here. The most recent quarter's follow-up statistics are always shaded because we know that children born at the end of that quarter, who will be about 5 weeks old by the time the reports are run, may still have some follow-up visits scheduled. So this data is likely to be a little bit incomplete. When you get your summary statistics page, the main point is for you to be able to compare yourself to statewide averages. So you want to look at the statewide rates and your own hospital's rates, which are at the bottom of the statistical report page. Notice that in the middle section of this report, we also have the statewide ranges. The highest performing hospital, the lowest performing hospital, and the number of hospitals that are achieving our goal of 100%. You can also look at your own current performance and trends. Is your refer rate going up? Is it going down? How about your follow-up rate? The first column in this report is the number of babies that are discharged home. It also will include babies that are discharged to a long-term care setting. Babies that died during their inpatient stay were transferred out of your hospital to another acute care facility with a NICU, or babies who are still inpatient in your hospital at the time the reports were run are not included. The back of the statistics page contains definitions and explanations for each column. You should be striving for 100% as your screening rate by hospital discharge, and settle for 100% by discharge or by 1 month of age. So if you do manage to miss a baby, equipment breaks down, or a mom gets discharged home early unexpectedly, but you're able to bring that baby in for outpatient testing and have a hearing screening completed before 1 month of age, then you're still meeting our statewide goals. We do like to see babies get screened prior to hospital discharge because we're more likely to capture them while they're a captive audience. You want to keep an eye on your refer rate trends. Increases could mean a problem with your equipment. But we also don't like to see a 0% refer rate because sometimes that means an equipment problem as well. Keep in mind that hospitals using ABR equipment instead of OAE equipment do tend to have lower refer rates than those using OAE. So as you compare your own hospital refer rates to the statewide averages, realize that those rates are being influenced by different method types used around the state. The ABR and OAE specific refer rates are noted on the details on the back of the summary statistics page. So this first set of columns on the left-hand side of the report are about the inpatient screening and whether you're not screened before discharge and the refer rate. The set of columns on the right-hand side talk about outpatient follow-up and how hospitals are doing with outpatient follow-up of babies that either did not pass their inpatient hearing screening or did not have screening done during their inpatient stay. So that first column does include a total of all babies that were missed inpatient or referred during their inpatient stay. Again, you should be striving for 100% of babies who needed outpatient follow-up to be receiving outpatient follow-up. Clearly, we understand that there will be some situations where families sort of fall off the map and are unresponsive to contact, and we aren't always going to get to 100%, but we're looking to lean and improve each year and each quarter in that direction. Timely follow-up means that they passed outpatient screening or had a diagnostic exam done, and with the findings of a normal hearing or a diagnosis of hearing loss, and had that all completed by 3 months of age. And that's the second follow-up column. And again, our goals for newborn hearing screening are for babies to be screened by 1 month of age and for diagnosis of hearing loss or diagnosis of normal hearing to be completed by 3 months of age. So if a baby has an outpatient rescreening exam and refers on that second screening test, and then goes on and has diagnostic testing done, but that diagnostic testing doesn't get completed until after 3 months of age, they're going to count in your any follow-up column in your favor, but they're not going to count as having had a timely follow-up. Every time the reports are run, all the included prior years and quarters are recalculated every time. So, for example, in this report, there was one child born in 2012 that didn't actually have any follow-up testing done. So for this sample hospital, the rate was 93%. If that child were to show up later, a whole year perhaps, even after their inpatient screening test, we would be able to recalculate that rate and show that 100% of children had follow-up. Obviously, if a child showed up that late, it wouldn't be timely follow-up. The other thing that we're looking at is for all of the babies who haven't had follow-up, part of the process of the quarterly reports and of your hospital newborn hearing screening process should be documenting that children have had a follow-up contact attempt completed by the hospital. And so for any baby that hasn't had follow-up, we want them to be reported as lost to follow-up, or and so that the percent of babies with the follow-up status still unknown should try to be at 0% eventually. Again, when you first get these quarterly reports, we expect there may be some data lag, and this is where you're going to be doing the reconciliation of your reports, which we'll talk about in a moment, to make sure that we've accounted for all of the babies. So in addition to the summary statistics that I just showed you, we also send out some detailed reports that list named information of children that were born at your facility. They're sent out to just specific contacts, those contacts at your hospital that have requested to receive the detailed reports. And the purpose of these reports is to verify and reconcile the information for specific babies. We've color-coded them to try and help you keep track of which reports are about which sets of babies. So the green reports are babies that still need follow-up documentation, either as outpatient follow-up testing that has occurred, or they need to be documented as lost to follow-up and that the hospital's contact efforts have failed. And I'll be talking about each of these reports more in detail. The yellow reports are a mechanism for quality assurance and to reconcile possible data entry errors. New since the implementation of the Vital Information Platform, the VIP, as the new birth certificate system for New Jersey, is a blue report that is in to help identify some incomplete records that need to be resolved. So these reports are currently sent out all 4 quarters. The quarterly reports currently come out in February, May, August, and November. As I mentioned, because they contain names and birth dates of children, identifying information, we will only mail them and we won't send these via email. We will also only mail them to hospital addresses. So if there's someone external to your facility, like a contracted vendor, that would like to receive a copy of the detailed reports, the hospital needs to send the EHDI program written documentation authorizing us to mail these reports to an address that's outside of the hospital. Obviously, you should treat these reports as you would any other protected health information. If there are people noted on your distribution list as receiving these detailed reports that will not actually be involved in providing services or responding to these reports, please switch their quarterly report distribution status to statistics only. Detailed reports include children meeting these criteria that are born within the last 365 days prior to the end of the quarter. This allows for us to reconcile cases of babies who had long inpatient stays and so maybe were born a quarter or 2 previously but didn't go home until more recently. It also allows for reconciliation of cases where the birth certificate information was not completed in a timely manner. So the first report we're going to talk about are your green sheets. And these reports include identifying information for each child that is documented as missed or referred on inpatient screening with no outpatient follow-up documented. The detailed reports are set up for you to reconcile your data and notes, complete any necessary next steps, and fax them back to the EHDI program. The due date at the top will be 35 days after the day the report was generated, because it gives us a couple of days to actually stuff those reports in envelopes and get them to you, and then so it should give you approximately 1 month after you receive the report to reply to the EHDI program. The first thing to do when you receive these reports is to verify that they really were inpatient misses or refers as indicated in the inpatient results column. Sometimes there are data entry errors in the birth certificate system, and the reason the children didn't have any follow-up documented is because they didn't really need outpatient follow-up. If that is the case, you need to have the correction made in the VIP system, then note that in the appropriate checkbox. Note that there are 2 separate checkboxes, one indicating that the hospital staff completed the correction to the VIP system, and the other noting that the correction request was submitted to the Office of Vital Statistics and Registration, abbreviated here as OVSR. We're going to discuss the VIP correction process a little bit later in this webinar. If this baby was truly missed or referred as inpatient, this is the time you should go ahead and submit the documentation that you did make your required follow-up contact with the parents using either our lost to follow-up form or using the follow-up contact log in the EHDI reporting module in the immunization registry. The administrative rules that define how the newborn hearing screening law is implemented require that hospitals make at least one reminder contact to families whose babies did not pass inpatient screening. And we require documentation of unsuccessful contact efforts. So if that contact that you made didn't result in the family getting follow-up, we need to know that you did in fact make that contact. Sometimes hospitals are hesitant to label children as lost to follow-up since they are still in contact with the family and they're hoping that follow-up will happen soon. Please be assured that when we do statistics and reports, we find and use the best of all available information. So if a child has been documented as lost to follow-up but subsequently has follow-up reported, they will count as having had follow-up completed. It is good to think of the lost to follow-up documentation just as a way to verify that you made your required follow-up contact and not necessarily that the child is permanently lost to follow-up. There is a comment line where you can document something other than these two options. Let's say you have a baby where you called the parent, so you know follow-up was done at a particular office, but the EHDI program didn't receive that report, so the baby is showing up on your list. So if you note that in the comment line and say, parent says baby was seen by Dr. So-and-so or XYZ audiology facility, the EHDI program will then reach out to that office and get a copy of the outpatient results. The other thing to keep in mind when reviewing these reports is there is inevitably some lag time while we run the reports and mail them to you. The footnote of the report will always indicate the cutoff dates for the reports. So, for example, if this report cutoff date says we're including follow-up forms received by 11/4, and you've talked to the family and they know that they had an appointment on 11/5, then they may be on your report. We may have the documentation for that baby. It just didn't make it to our office in time to keep that baby from showing up on your quarterly report. And again, you can make a comment in the comments field to let us know about those cases. In some quarters, you may not receive the screen page at all. Ideally, this is if all the babies that needed follow-up actually had it, and you've got a 100% follow-up rate. But you may also have children that didn't receive follow-up, but you've already documented your required follow-up contacts for that child. And in that instance, there will be no children left on your report because you've already provided that requirement to document your efforts. Another way to say that is if your needs follow-up column on the statistics form is 0%, for the most recent 4 quarters, you should expect to have no green sheet. While we're on the subject of documenting follow-up, I just do want to highlight a few best practices about follow-up efforts and documenting loss to follow-up. The EHDI program has found that phone calls to parents do seem to be more effective in actually getting children to services or finding out where they've gotten services than sending a reminder letter. So if you have the capability to do a phone call instead of a letter, it's a great idea. If the parent states follow-up was done, as I mentioned, ask where and when it was done and include that in your comments, and that gives the EHDI program a lot of information in order to track down that report. Documentation can also be done via the immunization system and the EHDI interface in that system. And anyone who is listening to this webinar who does not have access to the EHDI program is welcome to contact us for training. Okay. Excuse me. This is a screenshot of that New Jersey Information System EHDI interface. You can see that using this system allows you to see what outpatient follow-up may have been done and also allows you to generate the loss to follow-up form or documentation of your follow-up contacts. We also have outreach to parents being conducted by case managers that are contracted by our program. So you may see children noted on your quarterly report and find a comment in the lost to follow-up or follow-up comment section that some contact has been made to the parent. And you're wondering, well, why are they showing up on my quarterly report list if there's already documentation that someone has reached out to this family? The reason for that is because that any contact by the case managers does not relieve the hospital of their regulatory obligation of making a contact attempt. So we still need your documentation of contact done by the hospital in addition to any that was done by the case management unit. Now, I'd like to talk a little bit more about the impact of data entry errors and the importance of doing internal quality assurance on a more routine basis and not necessarily just relying on the quarterly reports for this opportunity to reconcile any data entry errors that may have been reported on newborn hearing screening results. We talked, when talking about the green reports, that it's possible that the baby did pass a screen, but was entered as a refer rate, and you'll see that baby show up on your quarterly report as not having had follow-up. You may think that since this child did pass hearing screening and everything is fine and the data entry will get corrected when the quarterly reports come out, that it's no big deal. And while we do want you to use the quarterly report to correct data entry errors, I would again ask you not to rely solely on the quarterly report as your cross-check. Because what might happen is an actual case here that I'm going to show to you. This is a true case, but the identifying information has been blocked out for privacy. This was a case of a baby who was born in July, so that was at the start of our reporting quarter. The results were entered in the birth certificate as a pass in one year and a refer in the other, and really the baby passed both years. The quarterly report that included the July, August, and September babies was sent in November, and at that time the hospital identified the data entry error and made the correction. But here's what happened between July and November, and this is our follow-up contact log and shows the contacts being made by our case managers as well as our Department of Health staff. So initially, the case managers reached out to the mom, was unsuccessful in reaching the mom at the number that was provided, so she then called the pediatrician and was able to get a working number. I want to mention that this case unfortunately represents a failure of an ideal EHDI process in multiple levels, not just documentation of the results in the birth certificate. Because ideally, the physician office at that point should have been able to tell the case manager that the baby passed the hearing screening, since providing a copy of the inpatient screening results to the primary care provider is one of our regulatory requirements. So they should have been able to say, I know this baby passed, and it could have ended there. But that didn't happen. So then the case manager did reach the mother. And again, she didn't know that she needed any additional testing done. Again, a different system failure, because as we discussed in our previous webinars, again, part of our regulations is that one requirement is to give the parents written documentation of the inpatient results. So this mom ideally would have been able to say, oh, I have this piece of paper that says my baby passed. But she didn't know that, and so she believed, because we were telling her we thought the baby didn't pass, that they didn't. So she said she'd make a follow-up appointment. She went to follow up at an ENT office. Again, a different system failure. That ENT office didn't know they were supposed to report the results to us. That necessitated a few other phone calls on our behalf. But eventually, we got documentation, and this baby had outpatient testing done. Sadly, though, that baby never needed outpatient testing done. So one data entry error in the system created a phone call to the wrong number, a phone call to the pediatrician office, 5 phone calls to the mom, 2 phone calls to the ENT office, and 1 unnecessary exam. So when we think about the cost effectiveness of doing newborn hearing screening, we need to keep in mind that if we're spending a lot of staff time tracking down babies who need follow-up visits when they really didn't need a visit, well, we could better spend that time reaching out to families who really do need a little extra help. And we also don't want to be referring babies for follow-up that don't really need it. So that's one of the reasons that I try and encourage you to do some more routine quality assurance of your data to make sure that everything that is being reported to the Department of Health via the birth certificate system is reported correctly. The yellow sheets in the quarterly reports are here to reconcile different sorts of data entry errors. And this report is titled Possible Data Entry Errors. There's now 3 sections to this report. The first section lists children who are noted as passing inpatient hearing screening, but who also had outpatient follow-up testing reported. And the reason given for that outpatient testing was a prior refer or a missed inpatient screening. The green sheets help us to capture data entry errors where the inpatient results are recorded as a refer and it was really a pass. These sheets are the flip of that error. As with the green sheets, if there is a data entry error, please correct it and note it on the sheet before faxing it back to us. And again, you're going to note whether documentation was done, the correction was done by your hospital staff or whether it was submitted to OVSR. Again, there may be some occasional situations where a baby did pass their inpatient hearing screening, and the reason for outpatient follow-up testing was checked as prior refer because either they referred on an outpatient test or there was just some confusion about the inpatient results. So if you do find that in reviewing and reconciling your report that it truly was an inpatient pass, you're just going to check that box and let us know. Another reason for you to do internal quality assurance checks is children are only going to end up on this report, and we're only going to find this error where they were incorrectly reported as passing inpatient if they actually do have outpatient follow-up testing done. For babies who don't show up for outpatient follow-up testing done, but we believe based on their VIP data entry that they passed, here are babies that are just not going to get any additional follow-up contact done and truly be lost to follow-up. Another comment I want to make about these detail reports is that correcting any data entry errors is going to change your statistics. So this is another reason your statistics pages may fluctuate from one report to the next, and why we rerun the statistics each quarter. So in this example, if this was a baby that really did refer inpatient and did have follow-up, if we're not including that in your follow-up rate statistics right now, and if we do, that'll bring your hospital's follow-up rate up a little bit. The second section on the yellow pages lists children that did not meet the JCIH requirement for follow-up. The JCIH requirement for ABR testing on babies with a NICU stay of greater than 5 days. Since all hospitals with NICUs have established this now as policy, most of the time these are data entry errors. Most often the method is documented in error, and it was noted as OAE when an ABR was done. The other thing that is sometimes documented in error is the number of days of NICU stay. Be sure that the NICU admission and discharge date fields in the birth certificate system are only reflecting the actual NICU days. The VIP system does have a way to separately capture NICU days and days in an intermediate nursery, also known as a special care nursery. So please be sure that when you're doing the data entry for NICU days, if you have a baby that move between a NICU, an intensive level nursery, and an intermediate level nursery, that you're not counting those intermediate days as NICU days, or you're going to be expected to do an ABR on those babies. Again, you're going to notify us of any errors, data entry errors, and how they were corrected. Or if there was a screening that was not in compliance with the rule, it was an OAE done on a baby that was in the NICU for more than 5 days, you would document that in that last box. We have a new third section of the yellow reports that was added with the implementation of the VIP system. The VIP system allows for the recording of a test method of a diagnostic ABR. And just a moment as my screen has suddenly gone away from me. Okay, bear with me, as my computer seems to be frozen. Okay. And give me a moment to catch back up to where we were. Just going to check with my co-presenter, Nancy. Are we back up and running?
Yes, I see the yellow form.
Great, thank you. Okay. Oh, sorry for that little delay. So, our new section of this report. Diagnostic ABR is used only in a very small number of cases, and it usually happens in hospitals that do have an audiology department, so it requires, it's a full diagnostic test, so we're assuming that's being done by an audiologist, and it also is usually only done on babies who have a long-term hospital stay and have the opportunity to have a diagnostic testing completed. But since it is done on rare occasions, we do have the ability to capture that. What we noticed when we first moved to the new VIP system is there were a handful of hospitals using screening ABRs that were inadvertently checking diagnostic ABR in the test method box. So when we do see those cases that seem that they are coded as diagnostic ABR and that may not be true, those are also going to be included on your quarterly reports for reconciliation. And again, to be documented as a data entry error that's being corrected or to be true. So now I'm going to talk about the process to correct data entry errors. So we've been talking a lot about data entry errors in the VIP system. I need to talk first, I think, a little about the VIP submission process. It's different from our old birth certificate system, and it helps to know how this process works so that you can understand how the corrections need to happen. So the VIP system has several release points at which certain fields are required. All of the release points may be completed at once, or the record may be completed as stages as more information is entered. The hearing screening fields are not required until the final release to allow for the entry of exams that may happen well after the birth date in the case of very premature babies. The first release point is known as the legal release and contains the fields required to generate a paper birth certificate for the child, such as the parent and child names and the date of birth. Once the VIP record has passed its legal release, any information entered in the hearing screening fields is available to the EHDI program at all points in time. So those final release points do not have to be completed for the hearing screening results to be available to the EHDI program. We can see the information as soon as it's entered once we're past that first release point. One of the things that's been a little bit confusing to folks in fixing data entry errors is there are different requirements for sort of different portions of the birth certificate. So any correction that's on the legal portion of the birth certificate, so by that I mean like the date of the birth of the child and the parents' names and the child's names. The parent says, oh, whoops, you misspelled my baby's name, we need to fix that. Those changes to the legal portion of the birth certificate can only be made by the town or city's registrar in the municipality where the baby was born. So the local registrar's office can change the legal fields. They can only change the legal fields. They cannot change any of the other medical and statistical information that's in the VIP system. So one of the things that's caused some confusion is initially hospitals have found data entry errors in their hearing data, and because other corrections were being sent to the municipality registrar, they were sending hearing screening corrections to the municipality registrar. And we don't want to do that. For any medical or statistical field corrections, again, there's sort of two steps to this. If the fields have not passed their release point that we just talked about in the system, then the hospital and only the hospital can make a correction to those fields. If the VIP record has passed all of its release points, including its final statistical release point, at that point, the hospital is unable to make a correction, and only the Office of Vital Statistics and Registration can make a correction. I do want to add one caveat to this, and right now the hearing fields are requested to all be in the statistical release too. There is one hearing field, the field that says was hearing screening done, that's actually being required in release point 1, and a correction to that to make it release point 2 has been requested and is still pending. So you can report information to that needs to be corrected to your data entry staff in your hospital, and they will need to see if they can fix it, if it's at a release point where they can fix it, or whether it needs to be submitted to OVSR. If information needs to go to OVSR to be corrected, they have a process. There is a VIP worksheet page that contains all of the data entry elements that are put in the system. They want to use that page, only the page where there has data that needs to be corrected. Circle the information that needs to be corrected. We want to be sure to write in the electronic birth record number, which is a number generated by the VIP system, at the top of that worksheet page. And then it's going to be faxed to the Office of Vital Statistics and Registration. I want to mention that if you report a correction to OVSR, anyone who's looking in the VIP system to say, oh, has that correction been made yet, you actually will not be able to view it currently. The reason corrections can't be seen in the VIP is currently all field edits are being treated the same. There are amendments to the birth certificate that are meant not to propagate back to the hospital, like a name change for a baby in a case of an adoption. And so currently the system is set up that all changes, whether they are amendments or corrections, are not viewable back to the hospital. And again, at some point in the future, that may change. When you are submitting corrections to Vital Statistics on the worksheet, make sure, and even just using the worksheets in the hospital, keep in mind there was a corrected version of the worksheet that has come out to better align the possible hearing screening results when you do use both test types, OAE and ABR. The original copy of the worksheet, actually, where we were supposed to have a comma in between the outcomes or the results, put separate checkboxes in and created some confusion. So there is a new corrected worksheet. That corrected worksheet should be available to you on the Handouts tab in the GoToWebinar panel for those of you attending live today, or are available from our program. We can email that to you. Again, I mentioned previously the desire to have hospitals do some internal quality assurance on their data and not just wait for the quarterly reports to come out. One mechanism you might want to use to do this is that there are reports in the system. The VIP system has the ability for hospitals to create ad hoc reports. And I have created a handful of EHDI reports in the system that are accessible to all hospitals and can be used. So again, a definition on how to run those reports is included in the Handouts tab of the GoToWebinar panel. Or for those listening to the recorded version, you can contact our program for how to use that. Typically, only one person in a hospital has access to the ad hoc report writer function. And essentially, you just need to pull open the report, change the date criteria for the date range that you're interested in, run the report, and you can get either a list of tests that are incomplete, babies that are missed screen and have been discharged home, or babies that referred on their screening, or all inpatient hearing screening results for a group of babies born during a specific time period. And if you use those reports, those may help you to do some internal QA. A new report that was included with the implementation of the VIP is the blue sheets of paper. I hope to be able to eliminate sending out blue sheets of paper in the future as hospitals adjust to the VIP system and are able to complete timely data entry on all records. The conversion to the VIP system, as with any system change, has been a challenge in some hospitals and has resulted in some records not being completed in a timely manner and hospitals getting backlogged on completion of their VIP records, including the hearing screening data. As a reminder, the EHDI rules require that you complete the hearing screening data in the birth certificate system within 1 week of the baby's discharge from your hospital. Since the discharge status and date fields are not required until the last VIP record release step, the EHDI program really doesn't know for sure if a baby has actually gone home until those fields are completed. And the discharge date may not be completed the same as the hearing screening date, and results may not be completed. And we do expect that for preterm or ill babies, they may still be in your nursery and hearing screening information wouldn't be done yet. But the Blue Report was created to identify records of babies that probably have been discharged home for your facility by including infants that are more than a couple of weeks past their delivery date and were term babies. Or it also includes preterm babies if a sufficient amount of time has passed and they are currently at least a couple of weeks past their expected delivery date, so that they've probably gone home. So infants are included in this report if they meet that criteria of being expected to have gone home by now, and they also have no hearing screening data entered in the VIP as of the date the reports were run. As we noted before, keep in mind that there will be some lag time between the report run date and you actually receiving the reports. So in reviewing this report, if you find the hearing screening fields are in fact valued for the babies on your list, it was likely submitted after the report was run and no additional activity is required on your part. If you have just a handful of babies on your Blue Report, you shouldn't be very concerned, and these may well be babies that are still in your nursery. The blue pages do not need to be faxed back to the EHDI program, and in fact, they tend to not be very legible because of the darkness of the paper coming through the fax machine. So they're really just for your internal use to work with your birth certificate staff and ensure that the hearing screening data has been input for these records, and to give you an idea of records that you may not realize are still outstanding. So that is the conclusion of our description of the EHDI program's quarterly reports and how you can use that information and how you should be reconciling those reports when you need them. If you have any questions, you're always welcome to contact our EHDI program. Our EHDI program email address is ehdi@doh.state.nj.us, or you can give us a call at 609-292-5676. So now I am going to check into our questions. And okay, for newborns in the NICU for longer than 5 days, should an AABR screening be conducted, or should they be referred for a diagnostic ABR as soon as they are discharged? For babies that are in the NICU for longer than 5 days, a automated ABR should be done in the hospital prior to discharge. Only babies that do not pass that inpatient screening will need to be referred for a diagnostic exam. I will note that also that a NICU stay of greater than 5 days is a risk indicator for a late onset hearing loss, and our regulations ask that you comply with the Joint Committee on Infant Hearing position statement with respect to follow-up of babies who are at risk for a late onset hearing loss. Currently, the 2007 recommendations do say that babies should have at least one diagnostic exam between 24 to 30 months of age. In some hospitals and some locations, there may be a outpatient audiologic exam recommended at closer intervals. Okay, and that's the only question that has been typed in. I am going to go ahead and unmute the phone lines and give you an opportunity. Before I do that, I'm actually just going to stop the recording.